Good morning, everyone, from Boston, and welcome to this dissemination meeting of the PRIDE Research Program. My name is Vikram Patel. I am a professor of global health at Harvard Medical School, and this program was funded by a Wellcome Trust Principal Research Fellowship that had been awarded to me when I was still at the London School of Hygiene and Tropical Medicine in 2016, and continued after I transitioned to Harvard Medical School in 2017. This is a program that involved a large number of collaborators and investigators. I will not be able to name each and every one of you and those who are on these subsequent slides, but suffice to say that the work is really a team effort. And today, apart from myself, a number of the key team members who have played a role across these 7 years of this program will be presenting some of the headline findings. This is just simply a slide to demonstrate to you the very large numbers of people. I know that my colleagues in Sangath have made a huge effort to keep track of all the colleagues who have worked with PRIDE since 2016 to date. I hope we've managed to include everyone's names, and apologies if we've missed a name here or there, but I think this is the most comprehensive list of not just our team in India, but also the collaborators and advisors who played such a critical role at every step of the process. Of course, none of this work would have also been possible without our extensive range of partner institutions. I need to specifically acknowledge the Public Health Foundation of India. When we began in 2016, the program involved a partnership between Sangath, which was the primary partner in India that implemented all the research, but the Public Health Foundation of India was also an important academic partner. The Population Foundation of India more recently has become a key partner in the dissemination of the training. You'll hear more about that, of one of the interventions that PRIDE developed. And then a number of school, university, and NGO partners who have also played a key role in, for example, the training programs that you'll hear about. Lots of public engagement, and again, you're going to hear more about the public engagement efforts that we were very grateful actually to the Wellcome Trust that alongside my principal research fellowship, there was also a supplementary grant that supported the public engagement effort, and a number of colleagues and partners who worked with us, both individuals and organizations like Quicksand, who played a key role. So the agenda for today is really, we have a 2-hour meeting, but I don't think we're going to need the full 2 hours. Essentially, we plan to speak for about 45 minutes to an hour. These are going to be brief presentations, starting with my own myself providing an overview of why we did PRIDE and some key aspects and innovations of PRIDE. We will then flip into 4 consecutive presentations describing the key findings of 4 different research studies. And then Shweta will speak about the public engagement effort, and then I will wrap up with some summary metrics on our achievements, our impact, and importantly, what the key takeaway messages are and our future research directions. And then we'll open it up for a Q&A. This Zoom window is equipped with a Q&A feature. So please just insert your questions in the Q&A. I believe that you can also unmute yourself when we get to that point in the meeting and ask the question directly if you prefer. So let me move on then about a little bit of a high-level introduction about this program. I don't think it needs, bears repeating the fact that young people's mental health, adolescent mental health, is one of the most important areas in the life course for us to be focusing our attention to. Not least because most mental health problems begin before the age of 24. It's estimated that about 50% of the total burden of mental health problems in the population has already emerged by the age of 15, and about 75% by the age of 24. And yet, of course, mental health services for adolescents are woefully underdeveloped. There are many supply and demand side barriers we need to acknowledge. Supply side barriers, of course, we're all familiar with. The lack of skilled human resources to deliver evidence-based interventions. But there are also many demand-side barriers. Adolescents traditionally have been a demographic that's very reluctant to seek healthcare for any of the healthcare needs, and particularly for mental health care. There is a very little context-specific research on early interventions that can be delivered in settings where adolescents are, for example, educational institutions, and which can be delivered by non-specialist providers. And of course, star sharing is something that has been a key feature of global mental health to address the supply-side barriers of the lack of mental health specialists. As a consequence of these barriers, there's a very large treatment gap. We simply don't have a precise estimate of this, but my own estimate, based on many surveys that we've carried out of adolescent mental health in India, would suggest that that treatment gap is as high as 99%, particularly in the low-income populations in which the PRIDE program was conducted. So the aim of PRIDE, with this background, was to develop and evaluate a suite of transdiagnostic interventions. By this, we meant interventions that targeted the full range of common mental health problems, both emotional and behavioral problems, among school-going adolescents, with a very definite focus on the delivery of these interventions in educational institutions, following the principle of meeting adolescents where they are. 7 years on, I think it would be fair to say that PRIDE has emerged as the largest adolescent mental health research programs ever to be undertaken in India, and indeed in almost any other low and middle income country, particularly in the context of its 5 key design innovations. The first is that we have adopted something that has become very widely used now, the notion of identifying practice elements or active ingredients, and by matching these evidence-based practices to common adolescent problems that were encountered in the local context. This really formed the foundation, the theoretical foundation of the interventions you're going to hear about. These interventions were designed for delivery by lay counselors, and here we were really borrowing on the rich expertise that Sangat had over the last 2 decades of designing interventions for delivery by non-specialist providers. And of course, there is now a very rich evidence base on the acceptability and cost effectiveness of task sharing in global mental health. The third is we embraced the notion of step care, which really is about delivering low intensity interventions as the first line response to a mental health difficulty. It's an approach that is aligned with the notions of resource efficiency, but is also, in fact, a very pragmatic approach in the real world. It also acknowledges that there is no one size fits all. It's aligned with a stage approach to mental health care, such that we acknowledge that a significant proportion of mental health problems do not need an intensive intervention. We innovated in many different ways, as you hear about again, with the use of digital technologies and a variety of different goals for the delivery of interventions, for their scale up, and to promote engagement with adolescents. And right through this 7 years, there has been an active engagement with adolescents, including particularly so in the co-design of the interventions. We worked in 2 sites in the urban low-income environment in Delhi and in Goa, which is, of course, the home of Sangat. Delhi is one of Sangat's key hubs, the 3rd hub being in Bhopal, right at the center of India. And so different aspects of the PRIDE program were conducted in Goa and Delhi. Of course, the public engagement effort you'll hear about was largely across the country. It wasn't just located in these 2 cities. So here is a kind of an infographic that describes the architecture of school mental health care that PRIDE evolved. The pyramid, of course, is familiar to all of you. It really reflects the step care approach. But just to talk you through each of these interventions we presented in a moment, at step 0 was essentially a classroom-based intervention designed to increase the demand for mental health care. Adolescents were encouraged or motivated to seek care from either a counselor who delivered a brief problem-solving intervention, and later on we adapted this intervention for self-delivery on a digital game. And then the final intervention was a more intensive modular behavioral intervention for non-responders to the step 1 intervention. As you can see on the right-hand side, as you went up these steps, you basically used more intensive resources, both in terms of the kind of duration of the therapy, but also the skills that the counselor needed. An overview of the methodologies that we used. On the left-hand side, you see a range of different methods. Again, this is something that we've developed systematically over 2 decades of work on design of brief psychosocial interventions. The use of multiple different methods, which we then, in a both a sequential way, but also to triangulate information that arises from all these different methods, to arrive at an intervention which can then be evaluated through randomized controlled trials or pilot studies. And you can see a summary of the different methods on this slide. In a moment, you are now going to hear about each of the different interventions in sequence. So at this point, I'm going to hand over to the first of the my colleagues who are going to be presenting these different interventions. And I'd like to invite Rachna Parekh now to speak about the so-called step 0 intervention, which is the sensitization in schools to increase the demand for care. Rachna, over to you.
Thank you, Vikram. So these sensitization interventions were implemented with a primary goal of improving help seeking among students who had elevated mental health presentations. A very major component of this intervention was to do a single classroom session, which spanned over 20 to 25 minutes, which is usually the usual duration of a class period in the schools here. So the entire intervention was delivered over 1 class period by the lay counselors who were then also engaged in providing care. They used an animated video to support discussions with the adolescent students, which basically highlighted the common stressors and coping strategies, essentially, that adolescents can use on their own, as well as they introduced what and when should they be seeking help and how they can access the PRIDE counseling interventions. This was followed by a moderated group discussion, which was a very lively engagement between the students and the lay counselors, providing them an opportunity really to talk about different aspects they've learned during the session, as well as share their own concerns about what and how of therapy, as well as provided them an opportunity to engage with the lay counselors immediately during the intervention and also refer themselves right after the intervention. An added component in the background, we also did whole school sensitization activities, which basically meant sensitizing teachers and displaying posters at prominent locations within the school to also keep the engagement with the program high. This particular slide depicts the flyer that we distributed to the students, giving very background information on the school counseling program and how to reach, and if it was really applicable to them. And then we also distributed a self-referral form at the end of such sensitization sessions within the classroom. This form on the reverse talks about various myths and facts for mental health problems as well as for therapy. And the later half of this particular referral form is actually a detachable slip where they can fill their name and their classrooms, class and divisions, and can either hand it over directly to the counselor after the sensitization session or anytime later on, but also deposited discreetly into a drop box that was stationed and installed at various locations in the schools. This is an image of a classroom sensitization in action, and we have the video being shown on a classroom projector. So we wanted to then see that what's the kind of impact the classroom sensitization sessions are making. These are relatively higher resource intensive interventions, and we were already doing some whole school sensitization activities. And we wanted to see if there was really an impact of using a classroom sensitization session over the numbers and the types of referrals that we were getting for the school counseling program. So we adopted a stepwise cluster randomized control design with 70 classes. These were randomly chosen from across grades 9 and 12. These included more than 3,500 students across the 6 secondary schools. And here we wanted to, this was implemented over a 3-time period of 4 weeks each. So in overall, it was 12 weeks with 2 short breaks because of festivities and holidays and exams. And the 70 classes were divided into 2 sequences of 35 classes. So as happens in a step-wedged design, the trial began with the first 4-week period where all 70 classes were just receiving the control condition, essentially only post-school sensitization activities, no direct engagement in the classrooms. After first 4 weeks, we then switched on to the second time period, where the first sequence of 35 classes received the classroom sensitization sessions, and we recorded the numbers and types of referrals over the next 4 weeks. And after the second time period of 4 weeks elapsed, the second sequence of the remaining 35 classes received the classroom sensitization intervention. And that's how the trial was completed over 12 weeks of implementation. The primary outcomes for this was definitely the proportion of students that were referred into the trial. And the secondary outcomes related to how they were referred was the source of referral. Did they come on their own, or were it teachers or parents or friends who referred them? And the secondary outcome we assessed here was whether we met with the number of cases or the proportion of cases who met the mental health caseness criteria or had the need of accessing mental health interventions and getting assessed subsequently. What we found was really encouraging. Approximately more than 800 students referred from these classes, and a large proportion of these came from the classes that had received the sensitization interventions. And we also saw that most of these referrals across the 2 conditions were actually self-referred. They had themselves referred themselves for the intervention, but this was even then significantly higher within the classes that had received the classroom sensitization interventions. When we looked at the clinical thresholds that the cases or the individuals presented among the referrals, we saw that while a majority of students who met the caseness criteria came from the intervention classes, essentially because they formed majority of the referred students, but the proportion of cases within each of these conditions was nearly the same. So the intervention didn't really impact the proportion of students who really had mental health problems being referred into the trial, but really more number of students who had mental health problems came forward to seek interventions through the classroom interventions. Relatively, these particular study findings deviate from what we have found with other mental health literacy interventions and their impact on the help-seeking interventions. We attribute that these differences might be related to a few things, and essentially largely related to contexts where they were delivering the intervention, in the sense that the intervention in itself was developed through a lot of iterative processes where a lot of contextual barriers were studied in depth through the formative research, and the intervention was developed in multiple stages involving students and teachers as well. And so it was a very refined intervention when we started the trial. Secondly, this intervention provided an opportunity for adolescents to directly engage with the lay counselors, and which could have helped in clarifying a lot of doubts about confidentiality, for example, or the process for referral, or what will happen if I refer, what happens in a therapy. This particular intervention is embedded within the larger host trial, which Daniel will speak to subsequently, which provided the counseling services to the students. And so effectively, if a student had referred through this particular trial and was assessed to, it would be just a week within which the assessment would be completed and the student would receive care. And then lastly, we can't really ignore that large the population was treatment naive. Thank you very much for this. Over to you, Dan.
Thank you, Rachna. And of course, as Rachna described, the adolescents who were seeking care could get care almost immediately in their own school settings through the so-called step 1 intervention, which was a counselor-delivered problem-solving intervention. And I'm now going to invite Daniel Mitchelson to take us through the work that we did around the design and evaluation of the step care interventions, both step 1 and step 2. Daniel, over to you.
Thanks, Vikram and Rachna. So I'm going to be talking about what we've referred to as step 1. That's a counselor-delivered problem-solving intervention. And we've conceptualized this as a first line kind of early intervention for adolescents who are presenting with common mental health problems. So we're thinking about anxiety, depression, and conduct difficulties. But we have also recognized that in terms of the reasons why adolescents may present, they don't refer to having anxiety problems or depression necessarily, but these difficulties occur in the context of a whole range of psychosocial stressors. So the problem-solving approach that we have put at the center of this intervention is very suitable for addressing this mix of kind of psychosocial difficulties that young people describe, as well as their emotional and behavioral kind of sequelae. The intervention itself is, as I said, based around kind of problem solving as the core active ingredient. It's intended to be delivered by lay counselors over 4 to 5 face-to-face contacts in schools. And kind of moving away from this conventional model of, weekly sessions over a number of weeks, as well as there just being 4 to 5 sessions, we, through a process of piloting, ended up with an accelerated schedule with adolescents being able to attend kind of a couple times a week. So the intervention can be delivered in its entirety over just about 3 weeks. And we have developed an acronym, POD, that stands for kind of the 3 different steps of problem solving. P, referring to identifying the problem. O is about generating options to potential solutions for the problem. And D stands for do it. So applying those solutions in practice. We've also produced a series of kind of printed materials that we've referred to as POD booklets. These sort of provide examples of applying the POD steps in practice through kind of illustrated sort of comic book style stories. And we also had a little bit of experience of applying this using a teletherapy approach during the pandemic. So this slide is just kind of showing a few scenes from sort of some of the delivery settings. So in the top left here, you can see what we refer to as a drop box. So this is on the wall of a school in Goa. And this was one of the ways that adolescents could put themselves forward for counseling. They could write their problem on a slip and their name and their class, and kind of in a discreet way drop it in one of these kind of locked drop boxes. And you can see here an example of one of the problems that a student has written out, and that says, I have a problem, some boys in our class teasing with boy's name and telling bad words. So I mean, this is intended to demonstrate that, clear-cut depressive symptoms, anxiety, conduct disorder, that was certainly not the picture in terms of the reasons why many of the adolescents were coming forward. And so that sort of is intended to demonstrate why kind of a problem-focused approach was particularly appropriate. You can see one of our supervising psychologists here in the bottom left, involved in a session with a young person in one of the schools in Delhi, and she's being observed by one of the lay counselors there. And then a couple of pictures showing scenes from schools in Delhi, and in the bottom right you can see sort of an improvised counseling space which is marked out in, I think, one of the libraries using this curtain, and it just sort of goes to show some of the resource constraints that our team face in these schools, even in sort of finding a private space for counseling. This is showing some images from the POD booklets. As I was saying, they sort of use a comic style approach. There were 3 booklets, each representing one of the 3 steps of POD, as well as sort of giving example, stories showing adolescents with some of the common problems that they face in the context. Demonstrated how they applied the POD steps and what some of the consequences were of using those steps. And it also had a series of prompts for the students using these booklets to start to think about some of their own problems and start to generate potential solutions for their own prioritized difficulties. Okay, so we conducted several studies of the step 1 intervention, and what I'm going to focus here on is sort of a randomized controlled trial that we conducted in Delhi. So this was a 2-arm RCT with an N of 250. It was delivered in government-run schools that cater to low-income families. And we compared the step 1 intervention, as I described it, delivered by counsellors but supported by pod booklets, with a control arm that consisted just of the pod booklets. So in effect, bibliotherapy. The adolescents who were enrolled in the trial didn't require a particular diagnosis, but they did have elevated symptoms that were assessed on the SDQ, as well as associated distress and impairment that we assessed on the SDQ impact supplement. And the primary outcomes in the trial were adolescent reported idiographic problems. So that's where adolescents pick up to 3 problems that were most concerning to them. They write those problems in their own words, and then they mark how much of a problem they are today, and then they reassess the same problems kind of at a later stage. And that measure is called the Youth Top Problems measure. And we also measured symptoms on the SDQ, and primary outcomes were assessed at 6 weeks, but we also measured outcomes at 12 weeks. And then we had a long-term follow-up at 12 months as well. We also conducted a process evaluation, and part of that involved qualitative exit interviews with participants from both arms of the trial. So what you can see on this slide is sort of the trajectory of outcomes on both of the primary outcome measures. So starting with the YTP scores on the left-hand side, and as I mentioned, the YTP is measuring kind of psychosocial problems that were defined in the adolescent's own words. And we found here on the YTP that problem solving delivered by counsellors combined with booklets was effective in reducing YTP scores compared with delivery using booklets alone, and the effect was similar in size at both 6 and 12 weeks, around about sort of D of 0.3. Now turning to the SDQ scores on the right, although there was a downward trend, this trend was sort of mirrored in both arms, and so the difference in SDQ scores between the arms was not significant at 6 or 12 weeks. But what we observed was that the gap did look like it was widening at 12 weeks. So then on the advice of our trial steering committee, we added a 12-month follow-up. So the 12-month follow-up wasn't originally part of the trial protocol. And what we ended up seeing, interestingly, and this was on both of the outcome measures, there was a modest sustained effect. And one interpretation of this is that newly learned coping skills were practiced and consolidated over time, and participants in the intervention arm were perhaps better able to sustain use of problem solving. And this explanation can be inferred to some extent from qualitative data that we obtained in our process evaluation. So this slide has just picked out a few indicative quotes from that process evaluation. So I won't read through these. I can leave it to you to sort of have a look while I sort of give a bit of a summary. But basically what we found was that POD was a helpful heuristic. Participants gained confidence in applying the steps to future problems, and they became more hopeful about tackling future challenges. Also, the booklets, as I mentioned, they were applied in both arms. They were generally helpful, especially with respect to the relatable stories. But the use wasn't necessarily sustained over time. So you can see this quote numbered 4 here. This was quite typical. So a student saying that, you know, they read them when they got them, they found them, you know, reasonably interesting to them in the longer term, and a number of students had misplaced the booklets when they were interviewed later on emerged as being really quite important. So learning and consolidation of problem-solving skills appeared to be strengthened through the counsellor's input, and the relational aspects were highly valued. But also young people appreciated more directive advice. So they appreciated the counsellor effectively giving them potential solutions that they could then go away and try out in practice. And I just want to bring your attention to this quote, to number 6 here. And so the student here is saying, the most important difference counselling made is that I met a guiding teacher. Now, in this case, this is actually a participant from the control arm, and there wasn't a counsellor. They didn't have contact with the counsellor, but they did have a very brief interaction with a researcher who, after this participant had been allocated to the control arm, the researcher just handed over the booklets and then spent a couple of minutes explaining the booklets. Now, even this very brief interaction was acknowledged by a number of participants from the control arm as being meaningful, and they didn't make a distinction between this researcher sort of being something other than a counsellor. They referred to the researcher as a counsellor in a number of cases. So I think what this is showing us is that even brief contact with a kind of a kind, sympathetic adult can be really motivating and be very kind of positively received. Okay, so I'm now going to say a little bit about this step 2. So it's important that we sort of keep in mind that one of the findings of the trial, it wasn't there on the previous slide, but when we came to look at clinical remission, so this was based on adolescents who, when they were reassessed later in the trial, dropped below the original kind of clinical thresholds on the SDQ, that clinical remission was around about 50%. And that's sort of within the benchmark range of kind of 40 to 60% remission rates that one sees in evidence-based psychological treatments for adolescent mental health trials, kind of in high-income countries as well, and often for sort of more intensive treatments. So on one level, this sort of 50% remission rate is impressive, considering the brevity of the intervention, the step 1 intervention, and the fact that non-specialists were used in delivery. But clearly there's room for improvement. If we've got 50% of adolescents showing on the face of it clinically significant symptoms, clearly there's an indication that something else may be needed. So that's the rationale behind step 2, reserving a more intensive symptom-focused intervention for non-remitted cases following step 1. Now, step 2, I think it's fair to say that out of all the interventions in the PRIDE architecture, is the one that has sort of gone through the greatest number of iterations, and it's probably the one where we've had, for various reasons, sort of the least amount of opportunity to kind of do sort of large scale evaluation. But the latest iteration of the intervention really reflects, I think, a simplification and a streamlining of the treatment protocol. So we've arrived at a protocol that consists of 3 behavioural modules selected according to the constellation of emotional and/or behavioural problems that the adolescent is still presenting with after step 1. So for depressive symptoms, there's a behavioural activation module. For anxiety, there's exposure. And for conduct difficulties, we have assertiveness and communication training. These modules are delivered over 4 to 6 sessions. And the idea is that treatment kind of consists of one kind of core module. So we're not expecting kind of 2 or even 3 of the modules to be implemented, but it's just one additional module is offered that's done over 4 to 6 sessions, and there's sort of 3 phases to that treatment. Getting started helps to bridge from step 1 to step 2. Then there's what we've called pick your adventure, where one selects one of the 3 sort of active ingredients. And then finally, there's a looking ahead, which is a sort of consolidation relapse prevention session. We've arrived at a point where step 2 is delivered by the same lay counsellor as in step 1, and also shared decision making is now part of this bridging process instead of using kind of rigid stepping up criteria. Now, as I mentioned, there's been a number of sort of iterations of step 2, but what this slide is showing here is a sort of summary of probably what's the key study that we've done, the key pilot study. That's the second of 3 pilots, and it followed the trajectories of 80 participants who were enrolled in step 1 with the option to step up. Now, this iteration was delivered by psychologists. So lay counsellors provided step 1, but it was a different provider who provided step 2. And the intervention was a bit longer than this now, kind of the 4 to 6 session protocol I described. And there are a few other sort of differences that I'll sort of say a little bit about. So what we ended up finding is that of those cases that were deemed non-remitted, so they still had significant symptoms at the end of step 1, only 36% of these non-remitted cases actually opted into step 2. And perceived resolution of their problem was the most common reason for opting out. You know, what ended up happening, you know, only a few cases sort of started step 2, and of those that started, fewer than half actually completed treatment. So of non-remitted cases who actually went through the full step 2 treatment. One of the reasons for this, as we identified in some of the qualitative work that we did, was a mismatch between sort of the standardized clinical caseness criteria for stepping up and a felt need for further treatment. So although adolescents may be showing elevated symptoms on the SDQ, they didn't necessarily feel like, you know, that they were in need of further treatment. So their main problem or problems had resolved through problem solving. And although there may have been some symptoms remaining, that they felt like they weren't a major issue, or they felt comfortable, confident in continuing to use problem solving to address those symptoms. There was also some dissatisfaction among students and also amongst providers related to quite a gap between steps. So there was a median of about a month between finishing step 1 and beginning step 2 for a variety of capacity issues with kind of the step 2 providers sort of not being available to take on new cases, and also just practicalities around sort of the school calendar, and sort of, you know, when there was holidays and so on, it sort of affected the continuity. And also step 2 was quite long in duration. On average, it was delivered over 10 weeks, and also some concern about shifting to a new provider. Okay, now what this slide is showing is kind of scores on the YTP over 3 time points. So we've got their initial scores just before they started step 1. We've got their scores at the end of step 1, and then we've got their scores where they were reassessed at a later time point. Some of them had done step 2, some of them hadn't done step 2. Now you can see the blue line shows responders to step 1. So scores drop off to problem solving and they stay low at follow-up without further treatment. If we then look at the orange line, this shows cases who stepped up after being non-responsive to step 1. And then you can see their scores drop down close to the blue line. And then finally, if we look at the grey line, that shows what happens when non-remitted cases opted out of step 2, their scores remained high. So these patterns are what we would expect to happen, what we, I guess, want to happen for a step 2 intervention if it were to have some value and incremental benefit. So certainly promising signs, but the caveat being these are really very small sample sizes. So I mentioned how few participants ended up going through all of step 2. And you can see the sample sizes at the in the legend to this particular figure. So certainly some promising signs, but definitely larger scale evaluations are needed. Moving on, here you can see sort of redesigned handouts for the step 2 module. So following on from that pilot I just described, we redesigned the handouts. There was some feedback from adolescents that they wanted more continuity between what the pod booklets looked like and then what they were provided with in step 2. And we also addressed continuity issues by switching to a single provider model. So that's to say the same counselor who provides step 1 also would provide step 2. And we also shortened the intervention and we added a shared decision-making protocol. Now, alas, the advent of the pandemic, when we were sort of on the eve of testing this new integrated step care model in a large study, it's just the advent of the pandemic meant that study was unfortunately sort of postponed, ultimately indefinitely. So it just wasn't possible to sort of to evaluate that. So we pivoted instead to putting a major focus on our digital platform. And my colleague Patty Gonsalves is now going to say a bit more about that.
Thank you, Daniel. So we're going to move quickly on to Patty's description of our approach to try and make the problem solving available on a digital platform. Patty.
Great, thanks Vikram. Thanks Daniel and Rachna as well. So Pride's digital problem-solving intervention is called Pod Adventures, and it aimed to take the same core content of the step 1 problem-solving intervention, but deliver it digitally via a smartphone app. And Pod Adventures was originally conceived to address the high demand for mental health support that we were seeing in schools when we were delivering step 1. Particularly among students who did not meet any clear clinical thresholds for mental disorders. And this very high demand could not be met by face-to-face interventions alone, and that was the reason for developing this digital counterpart. Unlike step 1 face-to-face delivery that Daniel just described, Pod Adventures was designed as open access, meaning that any student with a felt need for support could participate. They did not need to meet any clinical criteria. The intervention was gamified, meaning that we used elements and mechanics of games, so things like rewards, quizzes, motivators, and user choice. And it was initially developed for delivery in person in schools with brief guidance from a lay counselor. It was later modified, though, to be delivered during the pandemic online. Pod Adventures was co-designed with young people at our 2 research sites in Delhi and Goa over about a period of 18 months. We used a range of activities, including things like focus group discussions, design workshops, prototyping, and user testing as part of this process. The app itself consists of a set of interactive stories, so what are called adventures you see on the top left of the screen there. And these were based on students' own experiences or stories from their lives. Practice elements, so these were in the form of mini games. So these included activities like learning prioritization, relaxation, and emotion regulation. And a structured set of problem-solving questions for a student to apply to their own problem. So that was called the MyPod section. And in terms of the delivery, the intervention was offered, as I said, to any young person wanting help. They did not need to meet any criteria. It was offered in English with local language voiceovers in Hindi and Konkani, which were the locally spoken languages where we worked. And it followed a blended approach, meaning that we deployed low intensity human support through a lay counselor in tandem with the app itself. The duration was very short. So the app was designed, all of the content was designed to be completed in about 2 hours over 4 sessions. So we broke this up into roughly 30-minute sessions each. And as you see on the slide here, on the left, it was delivered in 2 formats. So the first being in a 1-to-1 format, and the second being in small groups of about 4 to 6 students each. in school. And the students were working on the app on their own. They were just seated in the same space together, and there was one counselor sort of supervising and supporting students as they worked their way through the app. When we piloted during the pandemic, we offered this online and in a one-to-one format that was provided on the phone. So we first conducted an in-person school-based uncontrolled cohort study with 248 participants in similar demographic schools that we described earlier on. These were low-income schools at our site in Goa. The aim of this study was to understand the feasibility and acceptability of delivering pod adventures in schools. And we also wanted to understand if there were any indicated sort of clinical effectiveness. And we looked at similar measures that Daniel described earlier. So perceived problem severity, mental health symptoms, and we also looked at stress and well-being. The findings of this study showed that pod adventures was acceptable, it was engaging, and it was feasible to deliver in school settings. And as you can see there, we had a high completion rate, good satisfaction ratings, and students reported finding the intervention helpful with solving their problems. Clinical outcomes on all the measures showed significant improvements, and these were actually maintained at 12 weeks as well. And large effects were seen on problem severity scores, especially. In terms of counselor efficiency, it took only about 10 minutes per student of counselor time in the groups format, so it was quite efficient to deliver to larger numbers of students. Immediately after this pilot, we had originally planned a full-scale RCT to evaluate the effectiveness of the intervention, but due to the pandemic, we had to modify the study to a pilot RCT. The aim was to understand whether the feasibility and acceptability that we saw in the school-based settings would be replicated when we delivered the intervention online with telephone support from a similar counselor. The intervention itself was not altered, but we did make minor modifications to deliver it online and also to recruit students online. And although we sensitized over 1,500 students, we only had 11 participants who enrolled and were randomized for the trial. There were unfortunately also no intervention completers and no outcome assessments were completed for students in the intervention arm, despite a range of motivators that were put in place for the intervention and sort of a lot of effort by the research team to follow them up. The main reason for non-participation was not having access to a phone or reliable internet. And it's possible that even completing the research requirements online was quite difficult for students. So these results contrast remarkably with the findings from the school-based study that I shared on the previous slide, which had comparatively higher rates of referral and higher rates of intervention completion. And although the study was completed during COVID lockdowns, these findings are actually quite consistent with what we see from many systematic reviews from primarily high-income settings, though, but that show that digital interventions have much greater uptake and engagement when they are delivered in structured and guided settings. So, for example, in schools. So it seems likely that an online study and this remote delivery format, rather than the contents of the intervention itself, were the biggest barriers to study participation and engagement. Finally, I mean, for anyone who's interested, the app is available online. If you'd like to have a look, you just need to visit the link down there. It's podadventures.in, and it's available on Apple and Android for download. Thanks, Vikram, and thanks, everyone.
Thank you, Patty. We'll move swiftly on to the final research presentation, which is Sonal Mathur, who will be telling us about the last bit of Pride's research work, which was to scale up the problem-solving intervention by developing a digital intervention for training of the non-specialists. Sonal, over to you.
Thank you, Vikram. So as we have learned about step one, that is problem-solving intervention, as well as the digital delivery, this particular piece of research is digital training in the step one intervention to scale up the capacity of our non-specialist workers so that they are able to deliver this intervention. And along with delivering this intervention, we also discovered that we did not have any brief measures of competency to assess the competency of the non-specialist. So that is something else that we also aim to develop. About this particular digital course, this is a self-directed digital course which has 20 hours of multimedia content. We've also, it's been an iterative process, and it's a lot of user testing where we came up with different formats such as lecture videos to explain a particular counseling concept, role play videos to demonstrate the concept, and other additional content like slide decks, supplementary reading, self-assessment quizzes. And these are all contents which are very short in duration to keep the engagement of the learners. This course is available in both Hindi and English currently. And we also have an optional individualized coaching, which is delivered remotely, along with the self-guided training, which is to motivate the participants. Now, this is basically the screenshots of what the course navigation and access looks like. This course is accessible on web as well as a smartphone app. These are screenshots from the app. So you can see the course progress. And in terms of the content, here are some more screenshots which are from the course videos. So you can see there are video lectures as well as the role plays. And we have very recently completed the evaluation of the digital training program, in fact, less than a month. So here what we've done is that we looked at the effectiveness of digital training in improving the competency of non-specialists, and also if coaching had any incremental benefits on the competency. So for this, we've recruited 277 non-specialists, and since it was a digital program, it was important they have access to an internet-enabled device like a computer or a smartphone. And our primary outcome was assessed by a multiple choice quiz that we have developed particularly for this study. As I mentioned, that was one of our aims. And to develop this MCQ, again, we have followed an iterative process, blueprinting the competency that are associated with our step 1 intervention, and creating the questionnaires based on it. After developing the questionnaire, after the pilot activities, we developed 2 parallel versions of the MCQs so that we could assess the competencies of trainees and compare it before and after the training as well, and without really having a practice effect of taking the same, writing the same test twice. So both the parallel versions, now each of this version has a unique case vignette and 17 items in each questionnaire, which are linked to that case vignette. So it follows like a counseling scenario from first session to the last session, and questions linked to the each session. And all our 277 participants from the training study completed either version of this form. And what we found in analyzing the MCQ results is that both the forms are quite similar in terms of the difficulty of the questions. They're very similar in terms of the information they provide about the respondents of different ability levels. And this, we have reached these conclusions after rigorous methodology of rash analysis. And after this preliminary validation, what we found was the tests were providing good information. Both the measures are reliable and valid. Only one item needed to be removed because of a negative discrimination score, which is not ideal. So now we have the 2 forms. Each form has 16 unique items. And for using this finalized measures, we have assessed the competency of our non-specialists after they've received the training. And we are in the process of analyzing those findings as well. But so far, what we have found is a strong evidence that the digital training increased competency of non-specialists by a mean of 1.66 on the competency scores. So as you can see, the effect size 0.5 We also found very strong evidence that digital training with coaching was associated with increased tailing completion as compared to an entirely self-directed digital training program. So participants who received coaching were 3.4 times more likely to complete the digital training than participants who were self-guided. And the findings for differences in competency score between participants who received digital training with coaching versus participants who receive self-guided digital training are awaited, and we'll be happy to share them with you as soon as we receive them. I also want to add that our digital course was developed in partnership with Population Foundation of India, and it has now been launched on their learning platform, Educately, which is open to the public. This is course which gives you an introduction to the counseling. It does not alone by itself qualify learners for professional practice, but it's a good learning step along with supervision to be for a non-specialist to be able to deliver the step 1 intervention. Thank you.
Thank you, Sonal. Let me move swiftly on to the final part of the presentations from my colleagues in Sangat, and I'm going to request Shweta to be very brief in describing our public engagement efforts with Pride. Shweta, over to you.
Thanks, Vikram. So hi, everyone. I'm Shweta. I'm going to be very brief and talking about the public engagement team at Pride. This work was carried out under a research enrichment award that was given to Vikram as part of the larger Pride study. The program was actually called It's Okay to Talk and It's Okay Baat Karo in Hindi, and is based on the core belief that talking about our mental health openly can help not only reduce stigma, but also help those who are experiencing distress to find the support that they need. The person that you're actually seeing on the slide before this is someone called Arunima Gururani. She's currently our social media manager, and interestingly, she started as a youth partner with It's Okay to Talk back in 2017 and now works full-time with our team. At the heart of It's Okay to Talk's strategy is the belief that sharing stories of people's lived experiences can have a profound impact, not only on people's perceptions and understanding of the subject, and that young people should be the drivers of mental health change. Our program has relied on young people, especially those who have lived experience of mental health needs at each stage of development, implementation, and evaluation. The main goals of It's Okay to Talk have been to increase young people's awareness about mental health, build their capacities to support themselves, and to reduce stigma about mental health. This program was meant to target the wider audience or wider ecosystem around a young person's interaction, which includes online and public spaces. And it comprised of 3 main areas of work. One was the storytelling website, a community-based events on arts, digital and social media campaigns, and training and mentorship for youth leadership. We expanded the work with It's Okay to Talk through the Wellcome-funded PE grant called Manmela. This produced a set of a web museum that featured mental health exhibits of personal narratives and psychoeducation resources. So you can see the Southern story where he spoke about how finding mental health support was extremely difficult for him. And this led him to set up an NGO that is dedicated to support queer mental health, queer young people's mental health in Northeast of India. Tarini spoke about how her experience of finding both discovering and accepting her mental health challenges and her diagnosis were extremely difficult, and how adopting a care routine that worked for her has been beneficial. These are some of the examples of psychoeducational materials that Manmela produced, and these were in English and Hindi. During the pandemic, we also launched a podcast that captured stories of young people living through the second wave of the COVID pandemic in India. These stories were captured both as a reminder and to support young people, but they remind us of the strength and resilience that young people showed through one of the worst times in recent history. At the end of the Pride Public Engagement Grant, we were able to ask young people who had participated in It's Okay to Talk about their recommendations for future projects on mental health awareness. And some of the key highlights that we received from them included these. So young people told us that, making information such as psychoeducation materials, guides, resources more accessible is absolutely crucial, and that these should be available in vernacular languages. They also told us that using stories of recovery and finding support is beneficial, and to leverage this activity even further. Young people asked us to build and facilitate advocacy skills in young people and to target wider stakeholders such as parents and teachers. Finally, they told us to work on suicide prevention and to train peers to support each other. Some of our reach impacts are actually highlighted on the infographic here. And in the 5 years that this program was active, we have engaged with more than 400 young people directly as artists, story contributors, and advisors, and trained about 50 young people in mental health leadership. Online, our reach has been even higher, and this has been supported by collaborations with large partners like Facebook and Instagram. Thank you, Vikram.
Thank you, Shweta. And I'm going to now just finish off with a summary of the key takeaway messages and impacts of the program. You've already heard about the very wide engagement that we had with stakeholders, in particular with adolescents. And you can see on the slide the numbers of adolescents who participated in various aspects of the research that we conducted. 32 schools in total in Delhi and Goa who have collaborated with us for the implementation of these activities. Pride is particularly proud of the efforts it's made in capacity building, particularly amongst early career researchers and especially in Sangat. Nearly 60 individuals have been involved as a programmatic staff, both as researchers and counselors, but also as administrative staff, including 15 counselors who were employed by the program, and of course, nearly 300 trainees of the digital training program. I'm especially proud that the vast majority of our publications were led by early career researchers, and amongst those, the vast majority by our colleagues who are based in India, amongst whom two, that is Rachna and Patty, who are on this call, have now received their doctoral degrees based on the work that they've done in Pride. You've already heard from Shweta about the extensive public engagement, and I'm not going to repeat much of that, but I'm just going to let you just scan this incredible reach that the Pride program had. And once again, I wanted to acknowledge the Wellcome Trust for its vision in not only providing the funding for the research that we conducted, but also supporting the public engagement that is so central to ensuring that both the research is informed by people's views and lived experiences, but that it also is disseminated through the wider community. In the last couple of years, we've begun to now scale up some of these interventions through partnerships with other implementers, for example, in New Delhi as well as in Bengaluru. And you can see examples of some of those partners. We already heard about the Population Foundation of India. But what I'm really excited about is how the work that we've done in India is beginning to inform the work that I am now leading in the US. In the last 3 years, we've launched this platform called Empower, which is essentially a platform to scale up brief psychosocial interventions by using a suite of digital tools that enables frontline workers to learn, master, and deliver these interventions. This infographic shows how Empower brings together a suite of digital tools and methods to design competency-based curricula, exactly as Sonal described that what we've done for the problem-solving training trial. We then develop a suite of tools for training the frontline workers who have completed the online course through case-based learning, and then ultimately credentialing through supervision and support, and then a suite of tools, including data science tools, for evaluating the scale-up of these interventions, as well as a variety of other research questions that digital data allow us to investigate. We're delighted that in the last few months, we received a grant from the Manton Foundation to begin to translate some of the work that you've heard about that was done in India, but adapt it for the US context and also bring on board US experiences led by John Weiss, who is a leading adolescent psychological scientist, targeting school counselors who work with adolescents in the US, and also delighted more recently that we've entered into a partnership with one of America's leading children's hospitals to examine how these same interventions can be scaled up through frontline workers who are working in partnership with pediatric and adolescent health services in the US. But I think this is a great example of how the work that was done in India is influencing approaches that we are engaged in now, not just the US, but in fact, we're now also in conversations with NHS England to bring these interventions to the newly established school mental health teams that NHS England is rolling out. And so alongside other innovation that Sanghat has developed, I believe that some of the work that Pride has done will also potentially have impact well beyond India. There's a number of new research grants and projects, including 3 Wellcome Trust active ingredient grants that were leveraged by members of the Pride team, as well as a recent Grand Challenges grant, as well as a number of activities that piggybacked and leveraged the work that It's Okay to Talk did, which you can see on the right-hand slide, that has also leveraged new funding from a variety of different sources, indicating the kind of additional impacts that the Pride research and public engagement effort has had, and of course the continuing work that the team in India is now currently engaged in. I want to finish now with some key takeaways and future research directions, just a couple of slides left. So the key takeaways really for those of you who want a summary really of what these last 7 years of work has taught us. We know for sure that classroom sensitization, particularly when delivered with context-specific messages in person, greatly enhances the demand for mental health care, addressing the demand-side barriers. And problem-solving delivered immediately after someone has sought care, delivered by a lay counselor, is not only effective in the short term, but seems to also have an incremental and sustained benefit over the longer term. Digital delivery of this intervention in an in-person school-delivered format is highly feasible and acceptable, and the training of frontline workers, particularly when coach-assisted, leads to an increase in competencies and clearly is a very useful first step in the process of mastering the intervention. That being said, you've also heard about the many challenges we faced, in particular that the counseling often conflicts with the primary educational agenda of schools. We also have observed, as Patty described, a significant barrier on the scalability of online interventions. And I think this should temper some of the enthusiasm that you often hear about in terms of the utility of fully online interventions. Clearly, from my experience, these are absolutely not scalable or practical in the Indian context, particularly for this age group. And I think the use of digital tools needs to be therefore really contextualized. And step care models are certainly the correct approach, given that 50% of students benefit from just a 2 to 3 week intervention. But on the other hand, they also extend the duration of the intervention, and we face engagement challenges. And so the next set of research questions really is a continuation of Pride to build on and address some of the challenges that I have just described. We're hoping that over the coming years, we will be able to leverage grants to support implementation science to evaluate the entire step care architecture embedded in a whole school intervention that Sanghat has also developed, which targets the social environment of schools. To conduct comparative evaluations of alternative strategies for the first step to see, for example, can we improve upon the effectiveness of the first step. And in particular, we're looking at behavioral activation as a comparator because of the very large effects that behavioral activation has had in both our work with young people in India, but also in the global literature. The adaptation and evaluation of these different interventions that we've developed for different contexts and different demographic groups, for example, young adults, but also, as you've just heard, the work that we are now beginning to roll out in the US. Addressing the needs of non-responders to the first-line intervention, for example, whether we should extend the first-line intervention versus adding a modular step 2 intervention, which is the approach that we followed in Pride. I'm particularly interested by the work of people like Jessica Schleider to look at whether we can even further enhance the scalability of our first step interventions by delivering a single session intervention, which clearly is probably the most scalable of all. And as work in this area has shown, is that a single session intervention, when carefully designed around a clear theoretical mechanism, can actually lead to very substantial rates of remission from acute mental health distress. And finally, looking at equity indicators in terms of the impact of these interventions on differential subgroups of the population.